morning, good afternoon, good evening po sa lahat. Saan mo pong panig kayo naroon. Welcome to our 238th episode, the Health Updates webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. And to all those who just discovered us today, welcome po at sana po marami po kayong matutunan, marami po tayong pag-uusapan sa araw na ito. But the overarching topic po is about atherosclerosis. So the escalating prevalence po nitong condition na to, atherosclerosis, and its formidable cardiovascular sequelae. It represents po a very, let's say, important or significant po public health challenge sa Pilipinas po. Tayo po mga frontline healthcare workers and professionals always at the forefront in managing and mitigating the impact of atherosclerosis. We are very fortunate for this week. We have a very distinguished panel of experts, and they will try to discuss, maybe help us out how to understand the pathophysiology of atherosclerosis, the origins on endothelial dysfunction and lipid deposition, and then eventually paano po siya nagfo-form into yung pong tinatawag po na nating mga plaques, yung mga nag-o-obstruct po, no? Ano po yung role ng genetic predispositions, ano pong role ng ating diet habits, lifestyle factors, and other prevalent comorbidities katulad ng high blood, diabetes, dyslipidemia, how do they all contribute to a heightened susceptibility of Filipinos to this condition. Obviously, we'll talk more about how we will be diagnosing this, ano po yung mga diagnostic modalities, including non-invasive assessments po, no? And then going into pharmacological interventions, but mostly also putting a focus on lifestyle modifications, paano po yung mga katulong, as well as yung kahalagahan ng early risk stratification, timely referral, and the initiation po ng appropriate management strategies. This is the Health Updates program, and I'm your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during our regular Friday. Also, my pleasure and honor again to host this program. Very, very fortunate. We have the head of the PGHS Integrated Training and Research Unit. She's also an attending surgeon from the Department of Surgery at the Philippine General Hospital, Dr. Marie Dion Sacdalan. Dr. Dion.
Good afternoon, Doc Raymond. Good afternoon to everyone. Welcome po, everyone, to all our participants here in the live broadcast of Zoom webinar, and to all those watching via live streaming on the TVUP YouTube channel, as well as on the UP System Facebook page, the TVUP Facebook page, and of course, all those watching from TVUP Signal TV channel 101. So as mentioned by Doc Raymond, we are very fortunate to have our speaker and reactor, Drs. Beaver Tamesis and Dr. John Anuevo, whom we will be introducing in more detail later on. So as you have seen in our opening billboard, we have shifted to a more generalized topic on health, and our theme is really on health updates, and we have done a little formatting from the previously COVID-heavy topics, but we are still maintaining the same high-quality discussion and then leveling it up to take a closer look at existing and emerging health problems in our country and the rest of the world. So before we proceed to the presentation, Dr. Raymond will introduce to us our person on the street video.
Thank you, Dr. Dion. Maraming salamat po. We want to be able to talk immediately po, no? How do we improve cardiovascular health outcomes para po sa ating lahat, lalo na sa ating mga kapwa Pilipino po. But before we go into the webinar proper po, no, we have our person on the street video just to set our discussion into context. We interviewed a few individuals po, no, with the following questions. Ano po ang alam ninyo tungkol sa atherosclerosis? May kakilala po ba kayong na-diagnose na ng atherosclerosis, at ano sa tingin ninyo ang nagdudulot nito? At sa palagay po ninyo, ano ang dapat gawin ng mga taong na-diagnose na ng atherosclerosis? Please watch this.
Based on my knowledge, ano siya parang blockage siya ng blood or ng sa heart. If I'm not,
I know that atherosclerosis basically is the blockage of the arteries because of too much fat basically in your blood. So
kung hindi ako nagkakamali related to sa blood, siguro yung malfunction ng blood, parang related siya doon. I'm not really sure.
Not sure about atherosclerosis, pero parang may plaque siya sa heart. Yun lang po yung alam ko about it.
Sa ngayon, wala pong kakilala.
Personally, I haven't, I don't know anyone who's diagnosed with atherosclerosis.
Since it's about plaques sa heart, as a CHK employee, feel ko sedentary lifestyle. I feel in unhealthy eating habits.
Kapag sa heart kasi yung problem, I think more lifestyle yung nagiging cause. For example, laging puyat, yung mga ganun, maling pagkain, choices of food. Yeah.
So from what I've learned, first genetics play a role. If you've got high blood pressure, your lifestyle as well. If you don't exercise that much and you eat very fatty foods, high sodium foods, so that really adds to yung risks of gaining atherosclerosis.
Feeling ko kapag yung tao siguro high blood. Hindi ko sure ha, kasi wala talaga akong alam about this. Pero based on my own understanding, based sa pagkakaalala ko when I was in college, dun siya about blood and if the person is high blood.
I think more on exercise, sa pag-diet, sa food, kailangan nilang manage yung nila, kung ano may kinakain nila, dapat limit nila yung mga not healthy foods. Ito po yung
As for treatment, di ako sure kung paano, pero to address the atherosclerosis, feel ko kailangan ng healthy lifestyle.
Feeling ko kailangan nila mag-exercise, sure na. And more water and healthy diet, I guess.
I think really consulting your doctor and as well as us nutritionists, dietitians to help you with the proper diet that you have to take when diagnosed with this.
Okay, thank you so much to our webinar team po, no, that taking the time out to really interview and go out of their way, find those who will be willing to interview. At least we have an indication po kung ano po yung alam po nila, but maybe they are much more on the other end of the spectrum, yung may alam na po patungkol po rito. But before we go into the webinar proper, we'll just few housekeeping rules po, no. I think that there are at least 2 people who have asked for questions po, no, patungkol po sa kanilang certificate. So for those who have asked via our up.edu.eph email, we will be responding to those. We're just doing our own counter checks. But please be reminded that certificates of attendance are usually given are only given to those who have watched at least 50% of the webinar duration. For our webinar today, we'll be having standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. Okay, we'll get our webinar underway. Dr. Dion Sakdal will introduce our main speaker for today.
Okay, thank you, Dr. Raymond. I have the honor to introduce our esteemed speaker, Dr. Beaver Tamesis. He's currently the president and CEO of Asian Hospital and Medical Center as part of the Metro Pacific Health Group. So Dr. Tamesis is a cardiologist. He has been board certified since 1991, and he's internationally published in both cardiology and diabetes care. He also continues to practice in the medical city where he previously helped develop the cardiology fellowship program. Dr. Tamesis brings with him over 2 decades of leadership experience in the pharmaceutical industry. He served as the managing director and president of MSD in the Philippines until 2022 before he became the president of Asian. He also
Okay, I'm not entirely sure. Baka she got frozen because of internet connections, Dr. Beaver. Without further ado, we'll turn the floor over to you, sir, and you can start your presentation.
Okay, thank you very much. I'll start sharing my deck. Let me know if it comes on.
There we go. If you can go to presenter mode, sir.
Yeah. Okay. All right, do you see my slide?
Yes, go ahead, sir.
All right, so first and foremost, thank you everybody for the kind invitation to speak. Talking to Stella in particular, bigla niya akong hinatak for this one. So let me see if I can get the laser. Okay, very good. So what is atherosclerosis in the first place? Where does it come from? Atherosclerosis is really a common disease that is the result of cholesterol. So it is the end stage of the process of accumulating cholesterol, particularly in the arteries. And diseases that are linked to atherosclerosis really are the number one killer in the Philippines and the world. All right. As the plaque builds up, the arteries kasi end up narrowing, reducing the supply of oxygen-rich blood to tissues and organs in the body. And when you have situations of rupture, yun, nagpaparat talaga yan, and suddenly the patient can go into sudden death or having a major stroke. Cholesterol naman is really a type of fat or lipid that forms many essential jobs in the body. Sa totoo lang, the body needs cholesterol. And the actual liver makes it. 80% pa nga of all cholesterol in the body actually comes from ourselves. Our liver makes cholesterol. So we actually need it. The problem is, what do we do if there's an excess, particularly if it comes from the food, right? And yes, we do absorb cholesterol from the gut. In fact, there's all these mechanisms, NPCL1, which is where predominantly where there is absorption of the cholesterol from the gut, and which is why this has become a target for drugs. There are other mechanisms by which pumapasok ang cholesterol into the lumen of our intestine, into the bloodstream, which will eventually get into the bloodstream as chylomicrons, eventually processed in the liver, etc., etc. So today, there are many, many ways that cholesterol actually is absorbed. So the body not just makes cholesterol, it absorbs cholesterol, it recycles cholesterol, right? So cholesterol is important to the body. Again, like I said, it's already 80%. So ang problema nga is what do we do with excess? Excess being either from too much intake or inability to degrade cholesterol. Why? Because the body actually uses this cholesterol that's circulating in the bloodstream. Ginagamit niya for all the processes. And this is particularly marked, very evident in women. Now, as they approach menopause, as a woman approaches menopause or is menopausal already, the estrogens actually decline in levels, and that now disables the loss of estrogen disables the LDL receptor or the receptors that collect circulating cholesterol from the bloodstream. So today, pag the liver is no longer able to collect or segregate the cholesterol from the blood, tumataas ang blood levels ng cholesterol. So in women, after menopause, about 55 to 60 years old, biglang you suddenly see a surge in their bad cholesterol levels or LDL cholesterol. Now, I've been using LDL and bad cholesterol. What does that mean? Actually, that is really a reflection or a classification of lipoprotein, the collecting mechanism or the carrying mechanism by which the body moves cholesterol throughout the body. There's HDL cholesterol and there's LDL cholesterol. And unfortunately, to the question earlier that was asked in the chat that I saw already, you cannot eat your way to have good cholesterol. You have to exercise your way to good cholesterol. You cannot eat that. However, the body has the apoprotein A, which controls mostly HDL, which removes the cholesterol from the arterial walls and brings it all to the liver. And you have the LDL cholesterol, which is now transporting cholesterol throughout the body, which carries naman ApoB. These proteins or these apolipoproteins there that are sitting there, be it ApoA, ApoB, yan yung mga that causes actually that's the one that actually leads to disease. In fact, more often than not, it's the ApoB rich the lipoproteins that end up causing myocardial infarction or the stroke. So remember that it's LDL cholesterol, it's called bad cholesterol, it contains the ApoB, which leads to all of this cholesterol getting into macrophages as it irritates the cell wall, the vascular wall, and then forming foam cells. These foam cells now actually incite inflammation in the arterial wall, particularly pag nabanatan yan with excess blood pressure, impact of smoking, etc., etc. It is now the cholesterol that accumulates into that arterial wall and where you now have the atherosclerotic plaque. So the disease process is atherosclerosis. The bala or the weapon is cholesterol, but the process is actually atherosclerosis that accumulates into atherosclerotic plaques. And it is not triglycerides, that's critical. It's cholesterol, particularly those in ApoB containing lipoproteins. All right. Now, how do we know that this is true? Because it's very clear now from all of the trials, all the randomized controlled trials, over 600 plus thousand patients enrolled over the last 30 years in all these trials, showing this correlation that every 1 millimole drop in LDL cholesterol leads to a 23% relative reduction in cardio events, in major vascular events. 1 millimole, that's approximately 38.67 milligrams per deciliter. So you can do the math. But basically, for every 1 millimole, 23% reduction. And this is applicable to both statin and non-statin treatments or combinations of these treatments. And all of the clinical trials just continue to prove it, no matter the mechanism that's really used to manage cholesterol. Statins, of course, have the biggest evidence now in combination with ezetimibe or these newer drugs called PCSK9 inhibitors, which can be very pricey at this point in time, but they're highly effective. And you can see that they all really bring down mortality in patients or events in patients having elevated cholesterol levels. And you can actually see the amount of reduction in cholesterol that you can induce by using these types of drugs. So yes, drugs work. And I know there are many of you who don't want to take statins. In fact, in my clinic, that's the first thing that patients ask me, when can I stop my statin? Guys, well, you're going to have to really do quite a lot to be able to control that, to stop cardiovascular mortality morbidity. And the number one then would be to stop all of the risk factors or the enablers of atherosclerotic processes. Number one, smoking. Now, I've been hearing the smoking, the reduction or the prevalence is now down to 20+%. I know back in the day when my dear friend John and I were still working on all our research papers as students, it was like 30+%. Now it's down to 20%, but still quite high. Basically, smoking damages the blood vessels. They cause these chemicals to damage the internal lining of the arteries, making them more prone to plaque buildup. They promote inflammation, again, accelerating the process of atherosclerosis. It also alters the blood chemistry, making it more prone to blood clotting. All right? And so, yes, it's definitely a cause of enabler for atherosclerosis. And we talked about that. And again, just to remind everybody, it's not nicotine that causes the damage. Nicotine addicts you. So for the smokers in the group, or if your patients are smokers, sorry, you're an addict. Addict ka lang sa nicotine. And then you're now hooked on to leading to all of the complications induced by smoking or vaping. Vaping is loaded with nicotine, kaya na-addict yung mga pasyente natin sa habit ng vaping. The other major risk factors, unfortunately, we can't do very much about diabetes because you either have it or you don't have it. And how does diabetes cause the problem? It's really that insulin resistance, which accelerates now the process and formation, particularly of small, dense lipoprotein. These small, dense lipoprotein are even more atherogenic than the regular LDL. Yung pala, yung LDL na yan, mayroon kang sub-classification. No? There's the regular LDL and the small, dense lipoprotein. And it is really important to know that that's happening because from small, dense lipoprotein, you actually have even more ApoB proteins circulating in the bloodstream versus the non-diabetic individual. Hence, we now understand why in the clinical cardiology world, when we see a diabetic, we think of that person as already having had a heart attack. Because they probably have had something, or this high ApoB, high small dense LDL particles, is probably what's already contributing to increased risk of coronary artery disease among diabetics. We treat basically a diabetic as a patient with ischemic heart disease. And yes, which is why in all of the clinical guidelines, be it the Europeans, be it the Americans, even the local Philippine guidelines, we treat the diabetic patient as somebody already in secondary prevention. So the target level natin for LDL-C is really quite low, as low as 40 milligrams per deciliter or a halos 1 millimole per liter ang target natin for the LDL cholesterol, just so that we can try to prevent secondary events or a repeat heart attack or a repeat stroke, right? And you can see the different guidelines, they're all available online. You can look them up yourselves. But basically, the lower the bad cholesterol, the better. Because there really is no bottom in terms of bad cholesterol, in terms of causing more side effects or risk to the patient. In fact, Aborigines, when they were first studied, or at least when the epidemiology or physical examinations were done on Australian Aborigines, their LDL cholesterol was something like 30 milligrams per deciliter. So you can really go very low with the LDL. It doesn't really hurt the patient to have a low LDL. In fact, it's probably better for the person to have a low LDL. Now, the other risk factors, somebody talked about family history. Yes, there is such a thing as familial hypercholesterolemia. Dr. Rodi and his team at the PGH did all of these studies, and it really affects about 1 in 300 people. We do have it here in the Philippines. Yes, it is present here. Somebody mentioned hypertension, elevated blood pressure. Of course, that will add to the stressors into the arterial wall. Obesity, overweight, especially today, now that we have so many drugs that can really help you lose the weight, it's really becoming something that at least we can do something about nowadays, aside from just diet and exercise, which we all know nobody adheres to, right? Very few people really adhere to that. But yes, there's so many things now that we can do to address obesity, blood pressure. Of course, there's so many drugs, there's so many generic and generically priced medication available. Other major risk factors include inflammatory diseases such as rheumatoid arthritis, psoriasis, lack of physical activity. Somebody asked about what are the non-diet, non-drug measures. Number one na dun is actually physical activity. A minimum of 150 minutes per week has been well documented to actually reduce death, reduce cardiovascular events, even reduce cancer. So yes, get up, get walking, 150 minutes per week minimum, not all accumulated on a Saturday or a Sunday, spread throughout the week. That will actually do a lot of benefits for the patient. Now, the only risk factor, of course, that we can't really change is age, all right? Sorry, we all get older, all right? Booting up, we're getting older, right? At least that means we're still alive. Okay? Now, there are many sample calculators that are available online that can actually identify, are you at risk already for having a cardiovascular event? They call it a CV risk calculator. And these are the key questions: age, gender, sex, cholesterol, HDL levels, blood pressure, are you diabetic, do you smoke? And this is just a sample result. I plugged in a few numbers and this is what the result came out. 19% risk in 10 years of having a cardiac event. But ASEAN, that's high. So you can see that even with nicely controlled blood pressure, because mababang good cholesterol, and the fact that you're diabetic, that can really change the risks and actually put you at high risk for having a CV event in the next 10 years. And yes, we need to control all of these factors. But that's where I have a problem. If you look at that calculator, it's talking about CV risk. Why cardiovascular? Why are we so focused on cardiovascular? Well, because nga, maraming namamatay sa heart attack, right? But if you think about it, even our local statistics, number one cause of mortality is ischemic heart disease. But number three is cerebrovascular disease. And if you think about it, these are blood vessel diseases where nagbabara nga yung ugat through due to atherosclerotic process. We're not focusing tuloy on the disease process that leads to the final manifestation, not like neoplasms. Number two ang neoplasms. They don't say breast cancer, they don't say lung cancer, they say neoplasm. So if you take the analogy and try to apply it here, shouldn't we be talking about atherosclerosis? Because atherosclerosis leads now to either the heart attack, the stroke, the peripheral arterial occlusive disease, the carotid occlusive disease, etc. So really, guys, I think it's a misnomer to just focus on the heart. That's why we really should be thinking more and more about atherosclerotic processes. Ang problema, who can even say the word? Diba? Hirap na hirap tayo to actually pronounce atherosclerosis. As I was watching the video earlier. Sa totoo lang, those guys are smart, highly educated, the people being interviewed. And they're all very young. They could actually even pronounce it. Because I did a similar study at the end of last year for Asian Hospital. Nobody could say the word. So, which is why here at Asian Hospital, we've decided, why don't we refocus the picture just a little bit and start talking about Ate Rose. So I'll jump over now to do a video. I'll escape muna from this presentation to show the video. I hope this plays.
Ang panghihina sa isang side ng katawan, baka si Ate Rose yan. Ang chest discomfort na may hingal, baka si Ate Rose din yan. Ang leg cramps na may ngalay, guess who? Si Ate Rose pa rin. In fact,
Dr.
kahit wala ka pang
Weaver?
nararamdaman, abangers na siya.
We're not seeing
Ni
the video.
Ate Rose. Short for Atherosclerosis. It's when cholesterol plaque buildup blocks the passage of oxygen-rich blood in the arteries. Sanhi ito ng cardiovascular diseases like stroke, peripheral artery disease, at heart attack. It's the leading cause of death worldwide. Bago lumala ang one-sided weakness, chest discomfort, or leg cramps, have it checked at Asian Hospital. Merong world-class equipment to detect artery blockages, international-grade medical service, and solid screening and treatment packages. Now that you've met Ate Rose, you can do something about it here. Asian Hospital and Medical Center. Alagang deserve, alagang sulit.
Okay, I hope you were able to see that. I hope you enjoyed it. Wait, let me go back to slideshow.
Dr. Tamesis,
Ah.
we didn't see the video, but we heard the audio. So
Oh,
maybe we
I'm
can
sorry.
yes, it's okay, but we can probably just get the video from
Yeah.
you and we'll just input it
It's actually
YouTube
available on
later on.
YouTube. On Facebook.
All right.
It's actually available on
Okay,
Facebook.
so we'll
Click
get that
over to
video
the
from you.
Asian Hospital page. Nandun siya.
Okay.
And
Thank
then
you.
tama. I mean, like we actually launched that video in January this year. And in April, we were actually pleasantly surprised to see that the Lancet actually published an editorial calling for a transition from a schemic focused approach to one that prioritizes atheroma, or the progression of atherosclerosis. So mukhang we're aligned naman with what the leading thought leaders in the world are starting to think about. That's not just about atherosclerosis. It's not just about ischemic heart disease. It's about atherosclerosis. So to support our campaign on the Atherose campaign, so that people understand the disease processes, Asian Hospital has embarked on a lot of these ad stills just to highlight the risk factors that cause atherosclerosis, the manifestations of atherosclerosis, how it all leads to heart disease and potential death, right? So hopefully we can actually get more vignettes to be created by the second semester, so we can reinforce the video. And coming soon, pending the Department of Health's approval, maybe we can even do a collaboration with Yossi Kadiri here. So yes, atherosclerosis, smoking, they really are BFFs. So what has been the impact, at least to Asian Hospital? What have we been seeing? Well, since we launched the video, we were looking at our data from last year, pretty flat, right? And parang in a world where number one killer in heart disease Napaka-flat ng mga numbers namin when it comes to coronary angiogram, ano ba to, angioplasty, and even open heart. But since we've started nga this Atheros campaign, a more holistic approach to the management of atherosclerotic vascular disease, we pulled together all our doctors and all our expertise, be it cardiologists, neurologists, pulmonologists, etc., endocrinologists. We put together also commercial support, such as discounts, etc., etc. We've actually seen a reinvigoration of our business in our cath lab. So the likes of Dr. Meva are getting busier and busier again. Another over 20+% growth over the previous year, at least year to date. So yes, a marketing campaign that's geared towards changing attitudes, re-educating the public, actually is an important partner of the scientific discourse. So yes, hopefully we can all beat atherosclerosis, and later on, by ensuring that we address all the risk factors, at least the major risk factors, we can beat atherosclerosis. So that's all I wanted to talk about for now. Thank you very much for your kind attention.
Okay, maraming salamat po to Dr. Beaver Tamesis. I really like the little ano po no, cartoon kanina po no. Thank you also for all of the graphs, Dr. Beaver. I learned a lot. I mean, everyone learned a lot po no. We'll call you again during the Q&A, but right now I'll take this opportunity to greet those who are joining us both domestically and internationally. There are those joining us from the Daraga Doctors Hospital in Daraga, Albay, Cagayan Valley Medical Center in Tuguegarao, Cagayan, Dr. Jose P. Rizal Memorial Provincial District Hospital in Dapitan City, Zamboanga del Norte, Saint Marina Kidney and Dialysis, Vigan City, Ilocos Sur, so from north to south po, no? And then Pasig City Health Department in Pasig, Metro Manila. Also those from the province of Bataan, province of Quezon, province of Laguna, Marilao, Bulacan also, Philippine General Hospital, obviously, the province of Rizal, especially University of Rizal System Health Services po. No? Maraming salamat. From Oriental Mindoro, they are also here. Thank you so much. From the city of Imus in Cavite and Santolan PT Center in Pasig, as well as Southern Philippines Medical Center in Davao City. And internationally, we also have our viewers. We'd like to give them a shout out from Saad Dalab, University of Blida 1 in Blida, Algeria. Ryan Hall Shanix Incorporated in Bridgewater, Canada, and Chonin Hospital in Taipei City, Taiwan, as well as University of Hail in Hail, Kingdom of Saudi Arabia. Thank you so much. So we'll jump right off to our reactor. Reactor po, not very new face. We've had him a few times here in the program po, no? You know him as well known po na practicing cardiologist, as well as the department chair for the Department of Medicine at the Philippine General Hospital. But he is also multi-awarded. He has been awarded as a Distinguished Teacher Award from the Philippine College of Physicians for his remarkable contribution to the betterment of medical field. Also has served as department chair for the Department of Internal Medicine at Asian Hospital Medical Center previously, where he set up po, no, the residency training program and recognized for extraordinary leadership in 2019. Very much a teacher po ang ating reactor. Without further ado, Dr. John Anunuevo.
Thank you very much, Raymond and Dion. And again, thank you for giving me this opportunity to be the reactor to a very good friend. You know, Beaver is a very good friend, a classmate. So allow me to call him Beaver. So let me just share my slides. Okay, I hope you can see it.
Yes, go ahead, sir.
Yes, go ahead.
Hold on. Okay. Okay, so again, no, this is really not a reaction. I asked permission from Beaver that I will make my lecture a little bit more of a complimentary lecture to give you more insights into atherosclerosis. And it's nice that Beaver talked about the risk factors that lead to the development of atherosclerosis. And I'd just like to spend a few minutes with the cardiovascular continuum. All those present here in our webinar Beaver talked about the risk factors. No, I think he spent a lot of time on dyslipidemia, blood pressure, and everything. Unfortunately, a lot of our patients are unable to control or manage well the risk factors, and they end up having target organ damage. And one of them is, of course, acute coronary syndrome. So if you look at this cardiovascular continuum, our goal as physicians would be to keep our patients on the left side, control the risk factors, and hopefully they do not develop target organ damage, and of course, eventually, target organ dysfunctions like heart failure and myocardial infarction, and eventually death. So I will talk to you more about our experiences of acute coronary syndromes, specifically the ST segment elevation MI in PGH. As I have said, myocardial infarction is one of the endpoints of uncontrolled atherosclerosis. And the burden of ischemic heart disease in the Philippines is really enormous. You can see that the PhilHealth claims for ACS from 2015 to 2019, 68 to 73 for every 100,000 population per year. And just to give you an idea, this is our own census. This is UPPGH census of the Department of Medicine, top 10 diagnosis of admitted patients. Number 1 and number 2 are actually the results of atherosclerosis, hypertensive cardiovascular disease, and heart failure. Rank 1 and 2 among our admissions in 2023 and 2024. You know, you have to realize PGH is a tertiary referral center. So we really get patients who are very sick, patients who already have multiple medical problems. And number 9 in this diagnosis of admitted patients would be acute myocardial infarction or acute coronary syndromes. That means patients who already have rupture of their cholesterol plaques due to uncontrolled risk factors. I will center my talk more on ST elevation MI. The reason for that is I just like to share with you what has transpired over the past few months because of the support of the PhilHealth to our patients who develop acute coronary syndromes. So in 2022, we made a study in terms of the burden of disease of acute coronary syndrome in PGH, and that's about 20% of our admissions would be patients with ACS. And among these patients with ACS, 10% of them will have the ST segment elevation MI, which talks about a complete occlusion of your coronaries. I'd like to share this data with you in terms of the patients that are admitted for ACS. A lot of our patients still come to the hospital after hours of having chest pains. And I think this is one of the reasons why most of our patients will already have developed some form of myocardial damage before being attended to. About 41% rather would still have their symptoms less than 48 hours from symptom onset before going to the hospital. Only about 44% will go to the ER within 12 hours from onset of symptoms. So this is something that I think would need to be improved, more information, more education to our patients. Reperfusion would still be the best approach to all patients with myocardial infarction. And reperfusion can either take the form of a primary angioplasty or a primary PCI versus thrombolytic therapy. And as long as your patient is within that window period of 12 hours from the symptom onset, you can still offer them primary angioplasty with stenting. Why is that so? Why is it very important to reperfuse or revascularize patients with acute coronary syndrome? Because the more muscles you save, the more cardiac muscle you save, the better the prognosis of your patient. Time is muscle. And you can see from these graphs that the longer the time interval from the onset of symptoms to intervention, the more damage is done to the myocardium. And that would relate to mortality. This is time to reperfusion, both giving medical reperfusion in the form of fibrinolysis versus invasive intervention like a primary angioplasty. If you're looking at the door to balloon time and the door to the drug time, you can see that there is an increased mortality to patients who have longer door to drug and door to balloon time. And this is something that we need to emphasize, that to encourage our patients that if they have something that looks like an anginal pain, they should immediately rush to our emergency rooms for hopefully being able to receive adequate therapy in the form of PCI or fibrinolytic therapy. Another result of our study in terms of the strategy that has been offered for our ST elevation MI. This was a data in 2021 to 23. 46% of our patients will get primary PCI. For a hospital, a public hospital that is able to offer close to 50% of our acute coronary syndromes is ST segment elevation. That is a very good data already. And I will show you that this has improved tremendously, especially with the approval of our PhilHealth package for our patients with acute coronary syndrome. Now, very quickly, I want to share this with everyone because this is some data where we, as clinicians or even as administrators, can help in terms of better delivery of healthcare to our patients with ST segment elevation MI. I talked to you already about patient delay, but there's also two other things that we can improve: the EMS delay and the system delay. Patient delay, we need more information, more community education initiatives that we should do to target the less well-served groups, public health messaging using language and images that will resonate with the less well-served groups. I think we can do something about that in cooperation with DOH. How about EMS delay? We don't really have a very efficient EMS, but I think we should already develop guidelines that patients who we think already are having heart attack in the EMS, in the ambulance, they should be able to bring these patients immediately to cath lab. And that's where interventions can easily be done. And lastly, the system delay. This is already the time from when the patient arrives in the hospital, there is contact already with the healthcare system to being given reperfusion. And in PGH, just to share with you, and I think this should be done in all hospitals, and I'm part of Asian Hospital already. Beaver mentioned already how good the ACS pathway is in Asian Hospital. And in PGH, we also have the ACS pathway. This is systematically being used, efficiently being used. And we really have seen tremendous improvement in the mortality and morbidity of our ACS patients. And I hope all those listening in our webinar today, if you're involved, if you're in a cath lab equipped hospital, You may already have this ACS pathway, but if you don't have, so that it is fluid, it is very smooth. Once a patient comes in the emergency room with ST elevation or with ACS, everybody already is aware of what his role is. And in PGH, we were able to come up with a heart attack response team. This is called the heart, where when a patient is admitted or is rushed to the emergency room, a heart attack code will be announced, and all the members will rapidly go to the emergency room. The system delay will also be improved with the development of what we call a network. And the STEMI network, this now involves coordination, collaboration with other hospitals nearby. For example, I'm looking at this network, and PGH is a PCI capable hospital. Those non-PCI capable hospital, we can develop some guidelines and recommendations on how they can efficiently transfer this patient to a PCI capable hospital. The goal is early recognition, shortening time delays to treatment, and optimizing patient outcome. This is what we envision to happen, a hub and spoke model where the STEMI care is performed best within an organized network. It is also a little bit unfortunate that in District 1, 3, and 4 of the NCR, PGH is the only one that is capable of PCI. There's a lot of referrals that go to PGH, and that's why we have a lot of patients admitted. And allow me to just 2 minutes additional information. As I have mentioned, there is already an ischemic heart disease, acute myocardial infarction benefit package. This started in December. Again, PGH and Asian Hospital and all the other hospitals that are cath lab equipped is using this already. This is a tremendous help to our less fortunate patients. They have the benefit, no balance billing for most of these patients, to avail of angioplasty and stenting. And so far, since we started this in December, we already have 181 patients that have been done on the PhilHealth acute myocardial infarction package. And this is just some of the data that we have. Still, a lot of our patients are male. And Beaver talked about the risk factors. You can see that hypertension still ranks number 1, diabetes and dyslipidemia. Also, a big chunk of our patients would have this. And this is exactly what atherosclerosis is. We need to control the risk factors of your patients so that eventually they stay on the left side of the cardiovascular continuum and hopefully would not end up having acute coronary syndromes that eventually will lead to congestive heart failure and death. A lot of patients still will have non-ST segment elevation MI. 30% would have STEMI. And so far, this is what we have right now. I talked to you about the initial data back in 2021 to 23, but look at now from about 50%, almost 80% or over 80%, 84% actually have now interventions for all our patients with acute coronary syndrome because of the benefit derived from the PhilHealth package. So if you are in a cath lab equipped hospital and unfortunately a relative of yours or you yourself will have an acute coronary syndrome, you can avail of this benefit from PhilHealth so that you are given adequate reperfusion therapy, which eventually will lead to better myocardial damage. So in summary, Beaver talked about atherosclerosis. I've shown you that spectrum of cardiovascular continuum. Let's keep our patient controlled with their risk factors so that they don't eventually lead to further problems, heart failure, and acute coronary syndrome. as STEMI or myocardial infarction ST segment elevation should be timely managed with the best reperfusion strategy. It can be medical, but right now the approach is more of primary PCI. Delays or gaps in the delivery of best care, I've identified 3 of them, should be addressed promptly. And lastly, remember this, atherosclerosis may be prevented with proper management of risk factors to prevent progression to end-stage disease and eventually death. Thank you very much.
Right. Thank you so much, Dr. John. And really your reminders and tips for everyone. Very, very timely. Interest of time, we'll call in Dr. Beaver Tamesis back for our Q&A. First question will come from Dr. Dion Sakdalan.
Okay, thank you, Raymond. We want to field in the first question, and this came from Dr. Joseph Tortona. He's asking, what are the recommended non-pharmacologic methods to prevent atherosclerosis? Maybe to include what type of exercise? And I know you mentioned this in your lecture already, but maybe Dr. Tamesis, maybe we can highlight these non-pharmacologic methods.
Right. Yeah, it's very clear that physical activity, even walking, at least 150 minutes per week. That's probably the simplest and easiest thing for everybody. Think about that. That's 30 minutes per day, 5 days a week. Ang dali-dali niyan, di ba? Now, of course, a low-fat diet is absolutely critical because, like, if you can really bring down the fat content in your food, that will go a long way towards reducing the levels of your bad cholesterol. Unless, of course, you have familial hypercholesterolemia, that's a totally different issue. So really, a very low-fat diet. So that means cutting out most meat. Cholesterol comes from meat, comes from animals. It does not come from plants. All right, so focusing on a high-fat, high veggie, high plant diet, these are the ways to actually help reduce the amount of cholesterol that we're actually eating in our daily diet. And then, what's the other question? Cooking. Well, of course, you want to avoid the mga saturated fatty acids. So that's actually quite a nice little topic, totally separate topic that we can really get into. Medium chain fatty acids, of which coconut oil is the #1 proponent, versus palm oil, which is the long chain fatty acid. Both of them are saturated, yet both of them have very different effects on the body. So not all saturated fat is necessarily bad. It's again the type and the volume of saturated fat, particularly yung cooking oils.
Okay, thank you, Dr. Tamesis. Any other advice, Dr. Añonuevo?
I think Beaver mentioned already the things that all of us can do. Lifestyle intervention is very important. Exercise, diet. Very important. I don't know, Beaver, if you touch this. Smoking cessation, very important. Alcohol intake should be always in moderation. So remember those 2 things also, especially smoking cessation. And if I may include vaping. Okay? Vaping is not a substitute for smoking.
Okay, thank you. Doc Raymond, you have some questions on your end?
Question, I think mostly their exposure. So I'll just amalgamate it. The question was about in urban areas there's a lot of air pollution. So in those areas, is it it's a significant concern? Does it contribute in the development or maybe in the progression of atherosclerosis? If yes, what can they do, or maybe what advice can we give to those patients? For Dr. Beaver and Dr. John.
Air pollution. Iba yung issues ng air pollution versus coronary artery disease or atherosclerosis, right? Air pollution is not necessarily the same as smoking. They're different issues. Iba yung particulate matter that you get from air pollution, like if you're standing in the corner of Makati Avenue and Buendia, talaga iba yung particulate matter, right? Versus the one what you get when you're actually smoking. So I don't feel that they're really separate. These are different issues. rather than the same one and the same. So let's not confuse them. They're a bit separate, right? So if we are talking about coronary or atherosclerotic processes, really what we must do is avoid smoking, tobacco, and vaping. Those are the three most important that we actually inhale. Yung vaping nga, di ba? I mean, like the flavoring of vaping, the flavor that you used to vape, that they used to addict you with, it's okay if you take it in, swallowing it, and let your tongue and taste buds enjoy it. But when you smoke it, iba na yung effects sa baga. And that's when you start seeing already the popcorn lungs that we actually start seeing on X-ray, the popcorn effect of vaping upon your lungs. So we really must avoid both habits, vaping and smoking.
Agree. Raymond, I
Okay.
think
Yes.
air pollution will probably be more associated with chronic lung problems or chronic lung disease, and rather than atherosclerosis.
Thank you, sir. And another one, because I had three questions about this. Meron daw po bang role I think the question is more on the traditional medicine, traditional Filipino medicine, meron daw po ba yung maitutulong kung magaganon sila? And then maybe conversely, meron po mas makakapalala po ba yon if they had atherosclerosis and they underwent that and then etc. Maybe ano po, that side of the coin, both sides of the coin, Dr. Bieber.
I get the desire to use traditional medicine, but I can tell you, hands on a stack of Bibles swear all sorts of oaths. If I address cholesterol, blood pressure, and diabetes, I can prolong your life an extra 20 years. And that's in my clinic, that's usually traditional Western medicine. And today they're so cheap with all the generics. I don't need to give you the 100,000 plus peso drug that's given every 2 months or so to be able to control your cholesterol. I mean, like with intense management and a real focus on this ABC, HbA1c, blood pressure, and cholesterol, you can actually prolong life by at least another 10, 15 years.
Very
John?
valuable information.
Okay. Dr. John?
Raymond, actually, I wanted to ask you, I'm actually curious and interested. Ano kaya yung traditional medicine that they were referring to? I'm actually, what are these, Raymond? Any idea what they're referring to?
No details, sir. So I'm just I also wanted I wanted the experts to be the ones to give the response to that. But I'm thinking maybe siguro pagka if they feel medyo, 'di ba, pagka ano po, no, medyo mabigat yung katawan or medyo nahahapo sila or something, they go to manghihilot or something. That's what came to mind. So maybe yun po, that's what they were referring to.
Unfortunately, well, of course, science will always dictate what we do to our patients, no? But at this point in time, there are no evidences, no scientific studies that would tell us that these interventions would make any significant changes in the lifespan or reduction of mortality or morbidity to our patients. So my answer is probably at this point in time, there are no traditional therapeutic regimen that will improve their prognosis.
I see a comment from Joseph regarding garlic.
Yun.
Well, I mean, like, I think if you look at the Western papers, they all talk about how there's a small drop in the millimeters of blood pressure. And really, small changes in blood pressure can reduce the consequences of hypertension. But you really end up smelling like Italian cooking with too much garlic.
You have to eat a certain amount of garlic. And that really is a big amount of garlic to get what Beaver was referring to. I don't think it's bad to eat garlic, but if you're looking at its benefits in terms of really lowering your blood pressure, that's a lot of garlic. Right, Beaver?
Yep. I saw another question about which statin is the best. In truth, I mean, like I came from marketing these drugs, right? In truth, statins all have equivalents. 10 milligrams of one statin may be the equivalent of 20 milligrams of the next statin. All right. But so long as you know the equivalent dose in terms of milligram content per molecule, you should be able to achieve a similar effect. Now, some statins you can go higher in terms of milligram content, others you end up with the side effects already. So, which is why it's also important to think beyond just the statin. Combination therapies actually work much better. Every time you double the dose of a statin, you're only adding an additional 6% reduction. So you double the dose, you only get negative 6%. However, if you combine it with another molecule, such as a ezetimibe, that's an additional 20% reduction rather than additional 6. So not necessarily pushing the dose of one is the way to go. You have to think about combination therapies. It's like blood pressure. Blood pressure now, we used to think monotherapy all the time. No, no, no. Today, it's all about combination therapy to avoid more of the side effects now. Yet get better control.
Yeah, Raymond, can I say something about this? This is
Yes, go ahead, sir.
very important for me. No, one of our major problems with regards to our patients who get discharged from our hospital, then they go home. Most of the time, they are unable to continue their medications. So again, for all our listeners, if you are unable to continue your medications and you are unable to go back to places where you can avail your free medications, please go to your local health centers. I believe there are free medications, and I think there are some statins that are freely given to our patients. So make that effort of going to your local health centers and getting free medications. In whatever form it is, there are different ARBs, there are different statins, as I have mentioned. Please, and there are different medications also for diabetes. If you are unable to buy because of financial concerns, if you are unable to travel back to PGH or to any other hospitals where you can get free medications, please avail of the free medications in your local health centers. I'm sure Beaver would agree with me, compliance to your medications is very important. That really makes a lot of difference to your survival. So please take the medications prescribed by your physicians. Thank you.
Right. I don't think we have any more time po, no? But maraming salamat po to our esteemed panel of cardiology experts. Not every day that we're graced with such insights po, no? At this point, we'll be launching our evaluation poll. It's 5 statements, 4-point Likert scale. I'll read through it, and hopefully everyone here will be able to answer po, no? You should be able to see it on the Zoom screen. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we will not be closing this until the end of our webinar. At this point, we'll also want to invite everyone. You know that we showed po last week an infographic commemorating, celebrating po our 5 years on the air. Can you believe it? It's been 5 years since the pandemic started po, no? And we're hoping you'll be able to see the QR code here. Maybe you can sign up for that one. We have a very small token po, no, of our big appreciation for each and every one of you. So if we can just put it down there maybe for 5 more seconds, and then we'll have everyone see it on the screen. There we go. And if you can scan that, you'll be able to receive po, no? We hope you'll be able to sign up for those tokens. Thank you so much. For next week, I think we'll still have to determine that, no, Dr. Dion, that our topics for next week. So also, we want to remind everyone kasi we receive po no questions. Saan po ba we missed the episode? Saan po ba namin to mapapanood tong episode na to? You can still watch us on the playback at the TVUP YouTube channel and at the TVUP Signal TV channel 101. So before we conclude po our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. So just go to www.youtube.com/TVUPPH. In the live tab, you will see 237 episodes. After today, 238 episodes na po siya. In the same YouTube channel po, no? You go to the shorts video naman po. There you will see our health updates shorts. These are very, very short po, no? Presentations, selected presentations that will feature in snippets so you can watch them at your own convenience at the TVUP YouTube channel. Okay, so this formally closes our webinar for this week. Makita-kita po tayo ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.